A very good morning to meet you all for this session. Hope you're all wide awake and brisk with energy, right? Some of you are already there for the 4 a.m. session. Okay, what we are going to do in the next 1 hour, we are just going to do questions. You're going to tell me the answers. I'm just going to give you crisp explanation, right? So the main thing is we are going to cover maximum information in the minimum time possible. That's what I want to do. And just to give you one small intro, for past 3 to 4 years, I've been doing NEET-PG recall in ADRPLEXUS. Thanks for the opportunity, ADRPLEXUS. NEET, PG and any set recall I've been doing here in the same ADRPLEXUS team for past 3 to 4 years, okay? So NEET-PG 2021 or 2022, whether it be 2023, definitely they have been asking standard questions covering all the topics in anatomy. And over the years, you can see that image-based questions have increased with case scenarios, okay? Always it is from the standard questions. Recently, I don't know how many of you wrote INICET or went for the, attended the INICET recall. Yeah. So the questions were different, but yet they were very standard, right? So you're with me? We'll start. Come on. Okay. So whatever I'm going to discuss in the next 1 hour, it's all from the previous year papers. Which of the following are derivatives of the ventral mesogastrium? Can you keep entering the answer in the text box? This is one important image. I just would like to spend 2 minutes on it. Okay. So you see a cross section. Guys, the audio video is clear, right? Anything is there? Any problem, any fluctuation is there? Please let me know. So this is a cross section image of the abdomen, probably at the level of, I've given you two options. Did you see that? It's probably at the level of T12. Okay, I'll tell you why. So you won't have a problem in identifying anterior and posterior. Yes, it's just going to be Chris explanation. I won't be wasting much of your time. This is your rectus abdominis. This is your vertebra. And you can see the liver on the right and the spleen on the left. So left and right, isn't it? Okay, you can identify the viscera here. Yes, so this is the liver. You can make out the stomach. You can make out the spleen. You can make out the kidneys. You can make out the suprarenal. Yeah, that's the suprarenal. You can make out the aorta. You can make out the IVC. What is this? Another blue color channel that you see in front of IVC. Can you tell me what is this? This is the portal vein, right? Am I right? That's the portal vein. So what are the structures that lie in front and to the right and left of the portal vein? To the left that you see here will be the common hepatic artery, and to the right that's going to be the common bile duct. So what is this region? Can you tell me? Come on. What is this region that lies behind the portal vein and in front of inferior vena cava? That's the region of epiploic foramen, the foramen of Winslow, isn't it? So the right free margin of lesser omentum. So what is C going to be? C is lesser omentum. Yeah. And from the anterior aspect of the liver going to the anterior abdominal wall D. Yes, most of you got it right. What could that be? That's the falciform ligament. I'll just take a red color to name all the ligament. Okay, A, B, C, D. That's the falciform ligament. Can any of you tell me what is that important structure you see in the inferior border of falciform ligament? Running in the inferior border of the falciform ligament. Can you tell me what is that? Yes, anyone? Inferior border of the falciform ligament contains ligamentum teres hepatis. What is it? What is it a remnant of ligamentum teres hepatis? That's a remnant of obliterated left umbilical vein. You're not entering in the chat box, right? Yeah, very good, doctor, right? Yes, obliterated left umbilical vein. One more question can I ask you? You remember the quinoid segments of liver, right? How many segments are there, doctor? 8 segments, right? This falciform ligament, it lies between which sectors or segments? Can you tell me, or can you just find it out? Okay. So these are all the high yield points related to this ligament. falciform ligament, what lies in its inferior border? Very good. Excellent, doctor. Excellent, excellent. So on the left side between the lateral segment 4 and segment 2 and 3. Very good. Okay. Yes. Excellent. You're all you're all set for your upcoming exams. Right. Now, what is B? Can you tell me what is B? Connecting the stomach and the spleen. That's going to be the gastrosplenic ligament. Am I right? What does this gastrosplenic ligament contain? It has the short gastric vessels that are the branches of splenic artery coming from celiac trunk. Then what is this A? A is connecting the spleen and the left kidney. The leno-renal ligament, isn't it? What does this leno-renal ligament contain? Very good, doctor. That it is going to contain this tail of pancreas and the splenic vessels. Excellent, Dr. Darshini. Okay. Yeah, tail of pancreas and the splenic vessels. Right. Now coming to the question. Okay, so we have seen the orientation to the specimen, we have seen what are the ligaments possible here, and we have identified what is the vertebral level of the section related to falciform ligament, all the ligaments, right? Now, going back to the question, which of the following are the derivatives of the ventral mesogastrium? So, you know, in the gut tube, you have the foregut, the midgut, and the hindgut. Yes, you got it easily. Here, anterior abdominal, posterior abdominal wall. What develops in the ventral mesentery? The division of what divides the ventral mesentery? The liver. Because of the development of the liver only, okay, at this part that extends between the liver and the foregut, that's going to form the lesser omentum. Between the liver and the anterior abdominal wall, we get the falciform ligament. What are the other ligaments of the liver? So it can be an image-based question, a cadaveric question, right? But you should be prepared. Yes, the superior and the inferior coronary ligament and the right triangular ligament, they form the boundaries for what? The bare area of the liver, right? And what is related to it, to the bare area of the liver? The right suprarenal, the diaphragm, the portosystemic anastomosis, the hepatic veins, IVC, everything related that, right? Bare area of the liver bounded by superior, inferior coronary ligament and right triangular ligament. Apart from that, okay, the left triangular ligament. So all these are the derivatives of ventral mesogastrium. Okay, what about gastrosplenic and lenorenal? They are the derivatives of dorsal mesogastrium. And further down, if you take the mesentery, the mesocolon, all that, that will be derivatives of the dorsal mesentery as such. Is that fine? Okay. So yeah, they put a question like that and they put an embryological image also. You should be able to identify this. Yeah, this will be the ectoderm. You can see the neural tube in midline, and below the neural tube, what you get to see? The notochord, right? This yellow color one is the endoderm. Video not clear. The net is the same. Is anyone else having the same problem? Or is it okay for everyone? Sure, doctor. Yes, please get back to me. Okay. Yeah. Thank you, Dr. Silambarasan. Okay, so someone want me to write more legibly. Yes, the ventral mesogastrium, it gives rise to the ligaments of liver. What are the ligaments of the liver? The falciform ligament, okay, the superior and inferior coronary ligament, the triangular ligament, the right and left triangular ligament. Is that fine? The dorsal mesogastrium will give rise to gastrosplenic ligament, leno-renal ligament, and the dorsal mesentery going to give rise to the mesocolon, the sigmoid mesocolon. Thank you. The sigmoid mesocolon, the transverse mesocolon, right? And the mesentery. So you should be prepared for this question, whatever image given, a cadaveric image or an image from the embryology textbooks, right? So here anchoring the endoderm gut tube to the anterior abdominal, that will be the ventral mesentery. Behind it's going to be dorsal mesentery. Now, of the structures given here, a few words about the development. Liver and the stomach are derivatives of foregut. Spleen is derived from the mesenchymal cells in dorsal mesogastrium. What about the kidneys? Kidneys along with the suprarenal, they are going to develop from the intermediate mesoderm, the adrenal cortex. Okay. You must be familiar, going to the next question. You must be familiar with this image, right? Can you tell me what is pointed out here? This is sort of an indirect question, isn't it? Yeah? You're supposed to know the derivatives of everything, remember? Yes, excellent, doctor. That is the paraxial mesoderm. Now you can answer me. Yeah, of course, it is the paraxial mesoderm. I've just twisted the question a little bit. So the paraxial mesoderm will give rise to the somites. What does the somites give rise to? Yeah, it will give rise to the sclerotome, a ventral sclerotome and a dorsolateral myotome. Isn't it? What is the sclerotome going to give rise? The sclerotome is going to give rise to, you have to just crush your brain a little bit to give the answer, but it's easy. You have to be knowing it. The sclerotome will give rise to vertebra and ribs. What about the myotomes? It's going to give rise to the muscles of the body wall, the back, the limbs, the body wall, everything. And in the paraxial mesoderm, about the cervical, very good, Dr. Thangati, very good. Yeah, she's real. Yes. Yeah. Right, now all of you are getting it, right? So the occipital somatomeres, the pre-occipital or the pre-aortic somatomeres, what do they give rise to? The occipital somatomeres will give rise to the muscles of tongue and the pre-aortic muscles of the eyeball. Okay, so the cranial nerves 3, 4, 6 that innervate the muscles of the eyeball and the cranial nerve 12, right, that innervates the muscles of the tongue except, can you tell me what is that except for? Palatoglossus, okay? Yeah, that can be a question again. So the cranial, very good, Dr. Shweta. Right. Okay. Yes. So this image is meant for that. But apart from that, can you make out the other structures here? Of course, this is the surface ectoderm. What does the surface ectoderm give rise to? Yeah, you're in the revision point, right? You're not hearing it for the first time. You should be able to give it at the tip of your fingers. The surface ectoderm will give rise to epithelial lining, the epidermis, right, of the entire body, the appendages of the skin, the hair, the nail, the glands that you see in the skin. What are they? The sweat glands, the sebaceous glands, the mammary glands, the lat. Do you want me to write it? Can I have an answer in the chat box? What are the derivatives of the surface epithelium, surface ectoderm? Okay, so remember it is the epidermis. You want me to write it? Yes, please. Then you have to rub it a bit, okay? I haven't put an empty slide, okay? So I'll just take, you have noted down 3, 4, 6, okay? So the epidermis, the ectoderm, important things that you want to remember is, right? It is going to give rise to the epidermis, the appendages of the skin, the hair, the nail, the glands, all the glands that you see in the skin, including the sweat glands, the sebaceous glands, the mammary glands, okay, mammary glands, the lacrimal glands, and which salivary gland is going to develop from the ectoderm? The parotid gland, right? Of course, the lens of the eye, not only the lens, the corneal epithelium. Because the, please are you there? The rest of the cornea, right, develops from the neural crest along, migrating into the mesenchymal cells, right? Whereas the lens, the corneal epithelium, the conjunctival sac, the eyelids, the lacrimal gland, everything comes from the epidermis. Okay, and then the terminal most part of the urethra, the vagina, all that is going to come from the ectoderm. Coming next, what is this one? That's the neural tube. What is the neural tube going to give rise to? That is going to give rise to brain and the spinal cord, isn't it? Do you remember the important points? Where does the fusion of the neural tube takes place? At the region of fifth cervical somite. When does the anterior neuropore closes? Remember, when does the anterior and the posterior neuropore close? Anterior neuropode 25, posterior neuropode 27. Exactly, Dr. Gopika, right. If the anterior, exactly, doctor, if the anterior neuropode or the cranial neuropode fails to close, then the baby is going to be born with anencephaly. Do you remember? Very good, very good, very good. Right, neural tube defects. Failure of closure of anterior neuropode is anencephaly, right? Coming to the next one. Mesoderm, okay, beneath the neural tube, right? What is this process that you see here? The notochord. Just two remnants for the notochord. Do you remember? The notochord is going to give rise to, yes, apical ligament of dense. You get, yeah. And the, yes, one more. The nucleus pulposus of the intervertebral disc. Am I right? We have seen the derivatives of paraxial mesoderm. Can you tell me what is the intermediate mesoderm going to give rise to? This is the region of the intermediate mesoderm, isn't it? Next to paraxial mesoderm. The intermediate mesoderm is going to give rise to, very good, very good, very good. Remember the gonads, the testes, the ovary, and the entire male and the female genital system. Because it has the mesonephric and the paramesonephric duct, it also gives rise to the kidneys and the adrenal cortex. Am I right? Okay. Now, lateral plate mesoderm is easy, right? You must be learning about it. The cavity that you see here, it's going to give rise to the pleural cavity, peritoneal cavity, and the pericardial cavity. This the somatopleuric mesoderm, which lies close to the ectoderm, giving rise to the parietal layers. And this planktopleuric mesoderm lying close to the endoderm, giving rise to the visceral layers of these cavities. Now coming to the most important one, I'll just zoom it a big and you're going to tell me what is the one that I'm pointing out. Yes, what is this? That is the area of, come on, easy. The neural crest cells, isn't it? Which has been asked properly. Yeah, very good, Dr. Silambarasan. So what are the derivatives of the neural crest cells? I'm rubbing that area of the paraxial mesoderm so that yes, you're having at the tip of your fingers, what are the derivatives of the neural crest? It is going to migrate to different parts of the body, right? It's going to give rise to the mesenchyme of head and neck. It is going to contribute to the pharyngeal arches. And do you remember I've given a mnemonic in the previous sessions? HCG. This is how I remember. If it's useful, you can take it, okay? In the heart, in the developing heart tube, it's going to give rise to the conotruncal septum and the valves, the atrioventricular valves and the semilunar valves. Right? Yes. Yes, doctor. Okay. And yeah, in the heart. Coming to the cells, what are the cells that are going to be derived from the neural crest cells? I remember this term, poems. The parafollicular cells of the thyroid, the odontoblast. Which part of the teeth does the odontoblast contribute to? The dentine. So remember, the odontoblast is from the neural crest, whereas the amyloblast that produces the enamel is from the ectoderm. Right? This initiate they've asked histological image of suprarenal and epiphyseal cartilage, right? Sometimes they can ask you a histology of teeth also, expecting you to identify dentine or the dentine or the enamel, the lower part of cementum, all that. So just go through a histological image of the teeth, right? Okay. Right. So parafollicular cells of the thyroid, the odontoblast, the enterochromaffin cells. M. Can you tell me what does the M stands for? For the melanoblast and the Schwann cells. Okay, the neuroglial cells. And lastly, G. G is all about the ganglia. Excuse. Whatever ganglia you want to name it. The cranial nerve ganglia, the ganglia like the trigeminal ganglia, all that ganglia, and then yes, the dorsal root ganglia, the ganglia in the sympathetic trunk, the parasympathetic ganglia, And the ganglia, parasympathetic ganglia that you find in the walls of the GIT, what is it? The myenteric and Meissner's plexus. So these are all the derivatives of neural crest cells. Okay. So in this slide, I've tried to maximum summarize the derivatives of ectoderm, the layers of mesoderm, the neural tube notochord, and the neural crest cells. One word about the endoderm. Endoderm is easy, yes, but still it is going to give rise to the epithelial lining of most of your GIT. Not only the GIT, remember the respiratory tract, also the epithelial lining of the urinary bladder, right? And more, yeah, the part of the urethra also. Okay, and the endodermal lining of the pharyngeal pouches, right? Is that okay? I think I spent more time on this, but it is important. Hope it was useful to you to revise, recollect. Yes? Okay. Which of the following market structures are derived from the second pharyngeal arch? You can tell me what is A, B, C, D. A, B, C, and D. A is the subcutaneous muscle that you see over the neck going towards the face and inserting into the angle of the mouth as rhizorius. What is A? Excellent, Dr. Gopika. Excellent. Okay. Yeah. B. B. The anterior belly of digastric. Is my handwriting improving? Okay. Anterior belly of digastric. Answer for last question, please. It is the paraxial mesoderm, the muscles of the eyeball from the occipital somatomeres. Yeah, the occipital somatomeres, the muscles of the tongue, innervated by 12th nerve. The preoccipital, the preaortic somatomeres giving rise to the muscles of the eyeball, innervated by 3, 4, and 6. So the best option is oculomotor nerve, right? Okay, doctor? Yeah. B is anterior belly of digastric. C, excellent. It is the stylohyoid. Yeah, it is the stylohyoid. I'll give you a clue. I remember it as SPB muscle. Stylohyoid. Yeah, in the cadaver also we have a confusion, right? So we have the stylohyoid above and the posterior belly of the digastric down. Okay, so I remember it as SPB muscle. And D is over the cricoid and the thyroid. I was just supposed to put it over the cricothyroid. Cricothyroid. Now you can tell me which of the following marked structures are derived from the second pharyngeal arch? What is the nerve of the second pharyngeal arch? Excellent. Nerve of the second pharyngeal arch. Yes. So it is going to supply both platysma and stylohyoid. I'll go with the option C. What is the nerve of the first pharyngeal arch? Mandibular. Second pharyngeal arch? Facial nerve. Third, glossopharyngeal. Fourth, vagus, external laryngeal, cranial accessory. And the sixth nerve, here is recurrent laryngeal nerve, isn't it? Have I given you the mnemonic for this? Yeah. My face got very red. Okay, this is how I remember it. Okay, quickly, what are the muscles innervated by mandibular nerve? Mandibular nerve innervates 4 muscles of mastication. What are they? Muscles of mastication, important, right? You can tell me what are the muscles of mastication? We have the temporalis, masseter, medial pterygoid, lateral pterygoid. Of the 4 muscles, which one is innervated from the trunk of the mandibular nerve? Which one gets the innervation from the trunk of mandibular nerve? Excellent. Which one is the only depressor? Of the 4, which one is the only depressor? Yeah, you get a case scenario, right? A student after in the post-lunch session, he starts yawning and then the jaws kept open. Excellent. Lateral pterygoid. Okay. So you should be able to identify the muscles of mastication in a coronal section also. Right? It's all going to be image-based questions. So look for the muscles of mastication in a coronal section. Right? And 4 muscles of mastication plus the 2 tensors. What are the 2 tensors? Tensor tympani and tensor veli palatini. Do you remember? The 2 tensors plus the anterior belly of digastric and the mylohyoid. So mandibular nerve, remember 8 muscles. The 4 muscles of mastication, the 2 tensors and 2 suprahyoid muscles, right? Excellent. Coming to facial nerve, did I tell you the trick how to remember the muscles innervated by facial nerve? The 7 group of muscles. The 7 group of muscles. The subcutaneous muscle of the scalp, the occipitofrontalis, the subcutaneous muscle of the auricle. Auricle is anterior, superior, posterior, right? And then the subcutaneous muscle of the face, the subcutaneous muscle over the neck, that is the platysma. Then within the ear, what do we have? Stapedius. And then the SPB muscle that I told you now, stylohyoid, and the posterior belly of digastric. These are the 7 group of muscles innervated by facial nerve. You will never forget it. Even after you become a PG, you can teach your juniors, right? Okay. The subcutaneous muscle of the scalp, the ear, the face, the neck, within the ear, and then 2 more, the SPB group of muscles. The rest is going to be easy. Third nerve, stylopharyngeus. Recently, in INISET, they've asked, right, the structures passing between the constrictor muscles of pharynx. Please do read about that. And through external laryngeal nerve, it is the cricothyroid. And through the cranial part of accessory nerve, muscles of soft palate and pharynx, all the other muscles of the larynx except cricothyroid innervated by recurrent laryngeal nerve. Now, one question to you. Pharyngeal arches, you must be having at the tip of your fingers, right? One question. What is the nucleus that comes under this column? What is the cranial nerve nucleus that gives rise to the special visceral efferent column for 9, 10, 11 cranial nerves? Is my question clear? Name the nucleus that comes under the special visceral efferent column for 9, 10, 11 cranial nerves. Excellent, doctor. Excellent, excellent, excellent. Yes, doctor, yes. It's the nucleus ambiguous. Very good. Yeah. Okay. Excellent. Nucleus ambiguous. Excellent. Okay. Now, again, few congenital anomalies which they keep asking regularly. You can tell me what is this congenital anomaly? It is a tumor of the primitive. It is the tumor of the primitive streak. Okay, a tumor of the primitive streak. Sacrococcygeal teratoma. Yes, it is the sacrococcygeal teratoma. It has contents derived from all the 3 layers, right? You know, the primordial germ cells is the one which gives rise to ectoderm, mesoderm, endoderm. So it will have all the derivatives. It is a benign tumor that occurs in the sacrococcygeal region. It is an anomaly of the primitive streak. Can you tell me why do you get to see this tumor in the sacrococcygeal region? You don't see it over the cervical or lumbar. Neural tube defects, right? It occurs anywhere from the top to the bottom. But tumor of the primitive streak is confined to the sacrococcygeal region. Can you tell me why? Because the primitive streak as such, okay, the epiblast cells, okay, doctor, the epiblast cells, okay, they give rise to the germ cells, I mean the layers of all the 3 germ. It gives rise to the, it is considered to be the precursor for all the cells in the body, right? The precursor for all the cells in the body is derived from the epiblast. It's going to give rise to the endoderm, the mesoderm, and the ectoderm. But which germ layer is first formed? If I remember correctly, the epiblast cells, right? It will migrate through so initially you have a bilaminar germ disc. It has only the epiblast and the hypoblast in the bottom, right? Now, at the cranial region, you have the formation of the precaudal plate. So that will help you distinguish this precaudal plate and the primitive streak. They are formed in the midline. So imagine a plate. So then you have to differentiate anterior, posterior, cranial caudal. Okay, so these events are going to determine that. So the midline is established by the formation of the precaudal plate at the cranial end and the primitive streak at the caudal end of the embryo. So the epiblast cells will migrate through this primitive streak and replace the cells of the hypoblast to form the endoderm and then the mesoderm and finally on the surface epiblast, forming the ectoderm. right? So this is what I remember. Yes. So as I told you, the sacrococcygeal teratoma is exclusively confined to the sacrococcygeal region because the primitive streak is there, right? Okay. So the other images that I want you to rush through. Yes, Dr. Darshni. The other images that I want you to rush through is gastrochisis. You should be able to differentiate it from exomphalus. And previously they've asked about ectopia vesicae, exostrophy of bladder, anencephaly. Okay, so all these images, even midgut loop rotations, the midgut loop abnormalities. Okay, so make sure you go through all this before you, uh, reach your exams, right? Now, I think we are winding up with the embryo. We have just gone through a lot. 30 minutes over. I'm sorry, right? Okay. Coming to this, easy. A 24-year-old female, difficulty of moving the thumb. What nerve do you want to clinch on? Multiple skin cuts over the forearm. The answer for the previous question, it is not. They've asked the incorrect statement. It is an anomaly of the primitive streak, doctor, not the precaudal plate. Precaudal plate is found at the cranial end of the embryo. Primitive streak at the caudal end of the embryo. The nerve involved here is thumb. Excellent, excellent, excellent. Okay. Yeah, median nerve. Okay, whatever is pointing towards the thumb or the index finger, most of the times median nerve. If it's ulnar nerve, it will be mostly pointing towards the ring finger or the little finger. And this scenario, just look for the cues that multiple skin cuts over the forearm, right? So over the lower part of the forearm, the median nerve becomes more superficial. It is liable. The patient's aim would have been to cut his or her radial artery, right? Suicidal cuts over the forearm injures the median nerve. Now quickly tell me, what is the answer? Excellent, yes. So what are the muscles innervated by the median nerve? In the forearm, it innervates the pronator teres, flexa carpi radialis, palmaris longus, flexa digitorum superficialis, and through the anterior interosseous nerve, flexa digitorum profundus for the index finger and middle finger, flexor pollicis longus, pronator quadratus, isn't it? And over the hand, it innervates the thenar muscles, the three thenar muscles, the first and second lumbrical. Am I right? So these are the muscles innervated by the median nerve. All the other muscles in the forearm, in the front of the forearm and in the hand is going to be ulnar nerve, right? So here you have to choose the best option, right? Flexor pollicis longus is innervated by anterior interosseous nerve branch of median nerve. Abductor pollicis longus, yes, you're right. This is the answer. Can you tell me what is its innervation? Excellent, Dr. Darshni. Very good. It's a muscle coming from the extensor compartment back of the forearm. Yes, Dr. Mohanapriya, Dr. Guna. The abductor pollicis longus is radial nerve, right? Pronator quadratus again anterior interosseous nerve. The lumbricals are innervated by ulnar nerve and median nerve. Okay. So this will be the best option. Anterior interosseous nerve, it's a branch of the median nerve. So the best option to go with it will be abductor pollicis longus. Is that okay? Any doubt over this question? Can I move on? Right? And this was asked. Yes. So I just wanted to correlate with the previous one. What is this test called? It's called the pen test. What muscle is it testing? It is, of course, it is for the median nerve. What muscle is it testing? It is testing, right? Excellent, doctor. Excellent. It is testing abductor pollicis brevis. Okay, abductor pollicis brevis. Can you try to do with me the movements of the thumb? So this will be flexion, extension, adduction. For abduction, we are lifting it up. Opposition, we are bringing in contact with the other digits. Okay. So for abduction, why not abductor pollicis longus? Can you tell me why not abductor pollicis longus? The abductor pollicis longus doesn't reach your thumb. It inserts into the base of the first metacarpal. Okay, abductor pollicis brevis that reaches the proximal phalanx of the thumb. So understood? The pen test is for the abductor pollicis brevis that is innervated by the median nerve. Okay, now, yeah. Injury shown, and you can get used to getting multiple images right nowadays after your recent INICET. Yes, injury shown in image A will correspond to which of the following? What is the image A? Don't hit me, okay? What is this image A? You're able to appreciate fracture of, come on, waiting for your answers. Fracture of, huh? Uh-huh, uh-huh, uh-huh. Excellent. That's the fracture of the medial condyle of the femur. You can make out the ulna. You can make out the radius. This is the humerus. This is the lateral aspect. This is the medial aspect. Are you convinced? It is the fracture of medial epicondyle. Accepting? It's the fracture of the medial epicondyle. Now tell me which nerve is involved in fracture of medial epicondyle. Thank you, doctor. In fracture of medial epicondyle, which nerve is involved? Excellent, Dr. Shweta, Dashni. Right, Prasanna. So it is involvement of the ulnar nerve. Now, you can tell me what image? 1, 2, 3, 4. One is winging of scapula. Which nerve is involved to winging of scapula? Name the nerve and the muscle paralyzed. Yes, the nerve winging of scapula. Very good. Long thoracic nerve and serratus anterior muscle, isn't it? Excellent. Image 2, I'm sorry, it is blurred. I wanted to put it as claw hand. Median claw hand. The ulnar claw hand, right? Or it is on the medial digits. The ulnar claw hand due to involvement of the ulnar nerve. And image 3, this is the ape thumb that I wanted to show. So involvement of the median nerve and the muscle paralyzed will be opponent's pollicis. And fourth, image 4, what is it? That's the wrist drop, right? And innervated, the nerve involved will be radial nerve. Is that fine? Now you are going to tell me additional questions. Fracture of the surgical neck of humerus. What nerve do you expect? It's all rapid fire. Come on. Axillary nerve. So atrophy of the deltoid muscle and that regimental badge of anesthesia. Remember, fracture of the shaft of humerus in the spiral groove. Radial nerve. Okay, who's going to tell me now? What are the branches given of radial nerve in spiral groove? Branches given off by radial nerve in the spiral groove. Branches, 2 muscular branches and 2 cutaneous branches. Yes, branches are 4 in number, 2 muscular branches. Branch 2, the medial head of triceps. Medial head of triceps and the lateral head of triceps, and 2 cutaneous nerve, the lower lateral cutaneous nerve of arm and the posterior cutaneous nerve of forearm. It's not brachioradialis, okay? Brachioradialis, extensor carpi radialis longus, it's given off just before its termination. The level of termination of radial nerve is lateral epicondyle. Please read about the radial nerve, the important points, okay? And supracondylar fracture, we were just talking now, right? Supracondylar fracture of humerus. What are the structures involved? What are the structures involved in supracondylar fracture of humerus? No, anterior interosseous nerve is given off there, right? The median nerve, anterior interosseous nerve is given off in the forearm. Median nerve and brachial artery. Yes, median nerve and brachial artery. Supracondylar fracture is common in children, right? Yes. So involvement of the brachial artery is going to cause a devoid, it's going to deprive the forearm from the blood supply. Radial artery and ulnar artery, the muscles, they go for atrophy fibrosis, Oakman's ischemic contracture. Very good, Dr. Dashni. So here I've tried to summarize the maximum information. We have talked about fractures of the humerus, nerve injuries and whatever signs and symptoms related to it. Okay. Again, one quick revision. Yeah. What is A? Pointing index, again median nerve injury. Flexor digitorum profundus for the index finger. Hand of benediction, again median nerve injury, flexor digitorum profundus. This, can you tell me, see? The book test. You can see the thumb being bent, isn't it? The right thumb. This is called Frohman sign. What is the nerve injured? Excellent. Ulnar nerve and muscle paralyzed. Adductor pollicis. Right? This is the card test, isn't it? Again for ulnar nerve. Muscle tested is palmar interossei. And figure E, this is again anterior interosseous nerve. Excellent. For flexor digitorum profundus and flexor pollicis longus. Excellent, excellent, excellent. Okay. So you're able to recollect everything. That's a good sign. Nerve injury, that was asked recently, right? So this is why I told you read all about radial nerve. So you should know its branch, right? Which cord it's going to come from, its course, its branches given off in axilla, its branches given off in the spiral groove, and its level of termination. And what are the branches before termination? What are the two terminal branches? The superficial branches and the deep branch, the posterior interosseous nerve. This is entirely motor, this is entirely sensory. This radial nerve, let me see, it's a chocolate question. It is going to influence the extension of elbow. It is going to influence the extension of the wrist joint. It is going to influence the extension of metacarpophalangeal joint, isn't it? It doesn't influence the extension of the shoulder. It doesn't influence the extension of interphalangeal joint. What are the muscles extending these two joints? Come on. The muscle that extends your shoulder joint, taking it back, backstroke of swimming. What is that muscle? Excellent, Dr. Darshani. The latissimus dorsi. Similarly, the muscle that causes extension of your interphalangeal joints. Lumbricals, yes, Dr. Gunachitran, Shweta, the lumbricals, okay, please don't forget. The latissimus dorsi innervated by the thoracodorsal nerve coming from the posterior cord, the lumbricals innervated by the ulnar and the median nerve. So the extension of the shoulder joint and the extension of your interphalangeal joint, not influenced by the radial nerve, doctors, okay? You're with me? Okay. Come on. Which of the following label structures contribute to O'Donnell triad, which is also called as the terrible triad of knee? You can help me identify. So this is anterior, this is posterior. How to identify medial and lateral? The lateral meniscus is small and circular. The medial meniscus is long and more oval. So you have identified. Now the other structures. Okay, I'll use the blue ink. This is the anterior cruciate ligament, the posterior cruciate ligament, right? As I told you, this is the medial meniscus. This is the lateral meniscus. Apart from that, what is G and H? G is going to be tibial collateral ligament. Can you tell what is H? H, one of the hamstring. It is on the groove over the posterior condyle of tibia. Semimembranosus, right? And B, can you tell me what is B on the lateral aspect? The tendon, which is intracapsular in origin, concerned with unlocking knee joint. Excellent, excellent, excellent. So you can see how close it is, right, to the lateral condyle. This is going to be the tendon of popliteus. And bit away from it, this will be your biceps femoris, inserting into the fibula. Excellent. Now, what are the structures involved in unhappy triad, terrible triad of the knee? I remember it as ATM. Yes, you'll never forget it. The anterior cruciate ligament. Yes, the tibial collateral ligament or the medial ligament of the knee and the medial meniscus. Right? Read about the bursas related to the knee joint also. Okay. This one. So this is the femur. You see the posterior aspect of the femur. So this is the upper end of the femur. This is the greater trochanter. This is the lesser trochanter. Okay, I'll help you in identification. So you're seeing the posterior aspect. Inserting into the lesser trochanter. You know what is the muscle inserting into the lesser trochanter? That is the chief flexor of your hip joint. The iliopsoas. The iliopsoas, right? And I'll tell you what is inserting here into C. That is the gluteal tuberosity. So can you tell me what inserts here? Gluteus maximus, maximum part of it goes for insertion into the iliotibial tract. That also receives the insertion of tensa fascia lata. So this is the gluteus maximus, right? That is going to be innervated by the inferior gluteal nerve. Inferior gluteal nerve, isn't it? What about A and B? B is the region of obturator externus. Obturator externus, that is going to be innervated by obturator nerve. And what you see on the greater trochanter, anteriorly will be minimus, gluteus minimus. This is gluteus medius, doctor. This is gluteus medius. So that is going to be innervated by the superior gluteal nerve. What are the muscles innervated by the superior gluteal nerve? This is again a high yield topic, right? It's going to be innervated by, come on, tell me, gluteus medius, gluteus minimus, and tensa fascia lata. Excellent. Recently under piriformis, the second line, the nerve to piriformis below that they are put as, yeah. So these are the muscles innervated by superior gluteal nerve. The muscles innervated by superior gluteal nerve, they are abductors and medial rotators of the hip. The gluteus maximus innervated by the inferior gluteal nerve, it is a lateral rotator of the hip. And the other thing, remember the Trendelenburg gait and sign? Yes. So if the left pelvis sags down, what is the nerve that is paralyzed? The injury is on the right side, right? So it will be the right superior gluteal nerve or the muscle supplied by it. Okay. Yeah, recent INI said they have asked about like you're totally prepared, but they shoot you with the unexpected questions. It was like that. What are the muscles of the foot, the sole, innervated by the lateral plantar nerve? Yes, only 4 muscles are going to be innervated by lateral plantar nerve. Do you remember? I've just put the pictures for this. Stay with me for next 1 minute. We can just finish it off. Okay. Always remember the abductors are on the borders. Okay. The abductors in the border. So in the first layer, this is your medial aspect. You see the great toe. This is your little toe, right? Lateral aspect. So over the medial aspect, this is going to be abductor hallucis. And this will be abductor for the little finger. Digiti minimi, isn't it? And in the middle, going to all the digits other than the great toe, flexa digitorum brevis. Is that okay? The 2 abductors and the flexa digitorum brevis. Right. In the second layer, remember there are 2 tendons. One going to the great toe is flexor hallucis longus. To the other digits will be flexor digitorum longus. Now easy. The muscle inserting into flexor digitorum longus, any idea what it is? It's called the flexor digitorum accessorius or the quadratus plantae. And originating from the flexor digitorum longus, similar in your upper limb, from the flexor digitorum profundus, we have the lumbricals. And in the third layer, right? Yeah, I'll just go to the third layer. You have the small muscles. For the great toe, it is going to be flexor hallucis brevis and the adductor hallucis. Here it will be the flexor digiti minimi for the little toe. And deeper layer, you will have the interossei, the dorsal and the plantar interossei. Okay, the plantar interossei and the dorsal interossei. Is that clear? So these are the muscles you get to see in the different layers of the sole. And now, what are the muscles going to be innervated by the lateral plantar nerve and the medial plantar nerve? The medial plantar nerve, it's easy to remember, it's going to innervate only 4 muscles. Only 4 muscles. Okay. 2 in the first layer. The abductor hallucis, the flexor digitorum brevis, right? And then the first lumbrical in the second layer. And in the third layer, the flexor hallucis brevis. All the others are going to be innervated by the lateral plantar nerve. Is that okay? So clear? So here coming again, flexor digitorum brevis is by the medial plantar nerve. Flexor digitorum accessory is lateral plantar nerve. Abductor hallucis is again by the medial plantar nerve. Right? The first layer. Abductor digiti minimi lateral plantar nerve. Flexor hallucis brevis medial plantar nerve, and all the interosseous lateral plantar nerve. So innervated by lateral plantar nerve 2, 4 and 6. Is that okay? Please, please, please. So Dr. Santosh, yes, this question on soul was like bit unexpected. But yes, just the layers, okay? The 2 abductors in the corners and the flexor digitorum brevis. 2 tendons and the muscles inserting and originating in the second layer. Third layer, 2 for the great toe, 1 for the little toe and the interossei. It's easy. Just remember the muscles innervated by medial plantar nerve. Which of the following sulcus will be affected on injury to pointed area? What is the pointed area? The pointed area is, which they've been asking again and again and again. It is the region of pterion, right? Excellent. So that is the pterion. What are the bones contributing to the pterion? Right? You see the frontal bone. You see the parietal. You see the squamous part of the temporal and the greater wing of sphenoid. Now, what vessel is related to it? Yes, it is the lateral sulcus or the Sylvian sulcus. To be more specific, the posterior ramus of the lateral sulcus. The branch that is related here will be the anterior division of the middle meningeal artery. Can you tell me through which foramen it enters the middle cranial fossa? It is a branch coming from the first part of maxillary artery. Through which foramen does it traverse? It has to pass through. No, Dr. Hari, take a minute. Yes, it passes through the foramen spinosum. Rupture of this artery will produce what type of hemorrhage? Extradural hemorrhage. And previous year they have asked with options. It is related to the lesser wing of the sphenoid on the interior. It is related to the insula of the cerebral cortex, and it is related to the lateral sulcus. It is related to the middle cerebral artery and the superficial middle cerebral vein that runs in the lateral sulcus over the insula, right? So whatever related to pterion, you should be knowing. This one, graft of the great saphenous vein, the nerve damaged. Easy, right? Guys, are you all there? Yeah, it is an easy question. The saphenous nerve. Can you tell me where does it come from? It is a branch from the posterior division of femoral nerve. You see it in the femoral triangle. You see it in the adductor canal. It contributes to the subsartorial plexus on the roof of the adductor canal. Right? It accompanies the great saphenous vein. Over the medial malleolus, it lies anterior to the great saphenous vein. Which part over the dorsum does it innervate? It innervates the, come on, we'll do the innervation of the foot. So can you tell me the skin over the first interdigital cleft that is innervated by the deep peroneal nerve. And here, the lateral border of the foot. I'm sorry, here. This is medial, right? Okay. Medial and lateral. The lateral border of the foot is innervated by the sural nerve, that is a branch of tibial nerve, right? And the the saphenous nerve that accompanies the great saphenous vein, that innervates up to the ball of the great toe. They call it as the first metatarsophalangeal joint, saphenous nerve from the femoral nerve. All the rest of the foot that you see here is going to be innervated by, appreciate, The medial border of the great toe, please appreciate the medial border of the great toe is also innervated by the superficial peroneal nerve. Now my question, are you there? Yes. Fracture neck of the fibula. Fracture neck of fibula, the sensation will be lost over which part of the foot? Sensation is lost over which part of the foot in fracture neck of fibula? Come on. Excellent. Deep peroneal nerve, right? Which compartment muscles are paralyzed? The muscles in the anterior compartment of leg. The tibialis anterior, extensor, hallucis longus, digitorum longus, peroneus tertius, right? And yeah, what type of gait you get there? The high stepping gait. It's the foot drop you're talking about, which they've been asking repeatedly over the years, isn't it? Okay, this one. NEET-PG 2021, they have asked, what about the nerves? The nerve injured following removal of the submandibular gland and its duct. Which nerve is closely related to the duct of the submandibular gland? Yes, it is the lingual nerve, right? This is the lingual nerve that is closely related to the submandibular gland and the duct. But apart from that, any other nerve you know? Of course, the 12th nerve also you can see in the submandibular region, right? Apart from the lingual nerve. Any other nerve? The marginal mandibular branch. In recent innocent, they've asked it, the marginal mandibular nerve. Yeah, supplying the muscles of the lower lip. This one. Is this one, Harish? Okay. So here, it is the answer is fracture. Depending upon the symptoms, you have to choose. When will you choose deep peroneal nerve? When it's related, the symptoms are related to the anterior compartment of the leg and sensory innervation over the first interdigital cleft. When will you choose common peroneal nerve? If something is given about the superficial peroneal nerve, what are the two muscles supplied by the superficial peroneal nerve? Peroneus longus and brevis. What do these muscles do? They evert the foot. So superficial peroneal nerve has two components, eversion of foot and sensory innervation over most of the dorsum of the foot. So in the given clinical scenario, if the patient is going to present with symptoms involving the superficial peroneal nerve, go for common peroneal nerve. Right, doctor? Yeah. So we are doing this, right? So the hypoglossal nerve, the lingual nerve, the marginal mandibular branch. Here, duct is given, right? Isn't it? And marginal mandibular nerve is not given in the option. Just because the duct is given, I'm going with lingual nerve. That is intimately, they're triple relation. They call it as triple relation. Okay, doctor? And even the cervical branch of the facial nerve, they all lie superficial. Like the cervical branch of the facial nerve is going to supply the platysma. You can see it there. The marginal mandibular nerve usually loops. It forms a loop. Lingual nerve and one more. Even the nerve to mylohyoid. This is the nerve to mylohyoid. It lies between the mylohyoid and the superficial part of the submandibular gland. Okay, so the nerve to mylohyoid is also related. But since the option is given by submandibular gland and the duct, this will be the best one to pick up. And you should be able to tell about the lesions related to these nerves also. Right? Which vessel aneurysm impinges on the optic chiasma? Guys, would you like me to continue? I'll just go with the questions at least, if you don't mind. Yes. Can we go ahead for another 10 to 15 minutes if you don't mind? Yeah. Thank you, doctor. Okay, so which vessel aneurysm impinges on the optic chiasma? So this is the optic chiasma. You can see what I've labeled here. One is the vertebral artery. B is the basilar artery. And 3 is the internal carotid artery. Yeah, thank you. So here, this is the anterior cerebral artery coming from the internal carotid and the middle cerebral artery is here. Okay, so the two anterior cerebral artery are connected by this anterior communicating artery. Anterior communicating artery and aneurysm of the anterior communicating artery is going to involve the middle part of the optic chiasma by a crossing of the nasal fibers. Involvement of the nasal fibers, what type of lesion you get? Right? Isn't it? The bitemporal hemianopia, involvement of the optic lesion. Now, you must be thorough with the blood supply of brain, right? I'm just going to throw you rapid questions. Can you tell me? Posterior communicating artery is a branch of internal carotid. Aneurysm of the posterior communicating artery affects which cranial nerve? Aneurysm of the posterior cranial artery. Excellent. You can see there, right? This is the posterior communicating artery. This is the third cranial nerve, right? Yeah, third cranial nerve. And the next question. There are three cerebral arteries. Which cerebral artery doesn't come from the internal carotid artery? Just now I marked internal posterior. Yes, remember the posterior cerebral artery, it comes from the basilar artery. There are two choroid arteries. Which choroid artery comes from the internal carotid? Which choroid artery comes from the internal carotid? The anterior choroid artery comes from the internal carotid. What about the posterior choroid artery? The posterior choroid artery is a branch of posterior cerebral artery. Okay, so please read about the blood supply of brain. It is all extremely important. Talking about the features of third nerve palsy. Do you remember the mnemonic I have given before in my previous classes if you have attended? Yes, PED. Yeah, so this is the right eye, this is the left eye. Which eye is problematic here? You can appreciate the ptosis in all the eye, right? So ptosis due to paralysis of which muscle? Levator palpebrae superioris, right? Levator palpebrae superioris is the only everter of the upper eyelid. What muscle closes the eyes? The orbicularis oculi innervated by the facial nerve. Is that fine? And external strabismus due to paralysis of, so here both the eyes should turn towards the left. You see a lag in the left eye, right? You're not able to adduct the left eye. Due to paralysis of which muscle? External squint. Medial rectus innervated by the third nerve. Am I right? And dilated pupil. Dilated pupil due to paralysis of, come on, sphincter pupillae. Sphincter pupillae. And lastly, loss of accommodation due to paralysis of ciliaris muscle. Right? Excellent, excellent. Right. Okay. So lesions of optic nerve also, please read about it. So here total blindness occurs only when there is occlusion of the central artery of retina. Yeah. Injury to that central artery of retina, and a tumor of the pituitary gland. A tumor of the pituitary gland, aneurysm of the anterior communicating artery can impinge on the mid part of the optic chiasma. Aneurysm of the internal carotid artery can injure the lateral fibers of the optic chiasma, right, leading to unilateral nasal hemianopia. Lesion of the optic tract, optic radiation is going to present with homonymous hemianopia, contralateral side. Okay, I'm sure you're thorough about it. Okay, going on to the next question. That was a bit easy. The last structure to be pierced in lumbar puncture. So this lumbar puncture, L3, L4 level to withdraw the CSF, isn't it? What are the structures you come across when you pierce it? What are the structures you come across? You have to pierce the skin, superficial fascia. What are the ligaments you come across? The supraspinous ligament, and then interspinous ligament, and then comes the ligamentum flavum, right? And then the dura mater, epidural space, dura mater, subdural space, and the arachnoid. Please remember the anterior longitudinal ligament that covers the anterior surface of the body and the posterior longitudinal ligament that covers the posterior surface of the body of the vertebra are not at all involved, right? So the question can be put in a Humpty number of ways. Remember, it is a high yield concept and has been asked recently. Okay. So the structures pierced during the lumbar puncture, make sure you have it at the tip of your fingers, right? Okay. Deep inguinal ring is due to defect in which, that was asked, right? Yes? Easy. Yeah, we are just revising together, right? You're not learning anything. We're just doing a quick revision. Another quick revision. Fascia transversalis is not only deep inguinal ring. Can you tell me something else? Modification of the fascia transversalis? The internal, from the margins of the deep inguinal ring, the internal spermatic fascia that covers the spermatic cord. Okay, also the iliopubic tract for the triangles in the laparoscopic procedures. Okay, iliopubic tract. Please remember triangle of pain and doom. And then internal oblique will contribute to the conjoint tendon and cremaster muscle, isn't it? Transverse abdominis again to the conjoint tendon. Okay, and external oblique, humpty number of things. The inguinal ligament, its modification, the pectineal ligament of Cooper, the lacunar ligament, the reflected part of the inguinal ligament. It can all be image-based questions, okay? And the superficial inguinal ring, from the margins of the superficial inguinal ring, external spermatic fascia. Of course, its relation to, I am not discussing the relation to inguinal canal and rectus sheath. And please remember, both internal oblique and external oblique, they are related to the lumbar triangle of Petit, right? It's between the external oblique aponeurosis in front, the latissimus dorsi, the iliac crest. And in the floor, you'll get to see the fleshy fibers of internal oblique. If you don't remember, please read about it, okay? Internal oblique, external oblique contributing to lumbar triangle of Petit. NEET-PG 2023, that section on spinal cord, right? Where dorsal column, only the lateral part injured. So what is the symptom manifested? Loss of proprioception accepted, ipsilateral or contralateral, arm or leg. Excellent, Dr. Muga, like Tangati Hariprakash. Very good. Okay. So the only thing that they keep asking, and again are the important ones. What are the sensations carried by the dorsal column? It is going to be discriminative touch, 2-point discrimination, proprioception, vibration, stereognosis. When they mention stereognosis, also remember it's going to, they're going to talk about the perception. The object is given in your hand, you're going to close and identify it. So that is also going to be related to the upper limb. Is this the slide you want, doctor, or the previous one? Sorry? Which was the slide that you wanted? Yeah. Taken it down, Dr. Vinod. Can I move on? Okay. If some of you are in a hurry and you want to leave, just throw your feedback, okay? Ultimately, your feedback is what motivates us, right? To give us the best to you. Okay, so here again, I want to tell the discriminative touch, the 2-point discrimination, vibration, stereognosis from the ipsilateral, and fasciculus gracilis is from the lower limbs and the lower trunk. Fasciculus cuneatus is from the upper limb and upper trunk, right? Okay, yes, Dr. Harish will do. Upper limb and the upper trunk, right? And the other tract that is important, coming to the ascending tract, the anterior spinothalamic tract carries touch and pressure from the contralateral side. Lateral spinothalamic tract, pain and temperature, contralateral side. Okay, so most of the spinal cord syndromes are related to it. So the arrangement of fibers also becomes important. In this case scenario, they put that the knife is pierced the lateral part of the dorsal column. So that is the fasciculus cuneatus, carrying sensation from the upper limb and upper trunk about T6 level, right? Yeah, so ipsilateral. And remember, both in the corticospinal tract and spinothalamic tract, it's exactly opposite to the posterior column, the arrangement of fibers from outer to inner. We saw in posterior column, the cervical fibers were lateral most. In the corticospinal and the spinothalamic tract, the cervical fibers are innermost. That is why in syringomyelia, what happens? Syringomyelia, a cavitating lesion of the spinal cord involving the crossing of the spinothalamic tract, the cervical fibers are involved first. Bilateral loss of pain and temperature over the shoulder region, cape-like deformity. Do you remember? Yes, that's because of this. Yes, doctor. Okay, identify the given image. Easy. Now, can we do all these questions without much explanation? Okay, you can read. Yeah, whatever done, I would like to cover. So that is the circumvallate papilla. Just one question I'll put. What is the nerve innervating it? The nerve supply to the circumvallate papilla is from excellent, ninth nerve. Okay, the fungiform papillae is the seventh nerve. It has the taste buds. Foliate papillae also has the taste buds. The filiform papillae has a keratinized tip. It doesn't carry the taste bud. If they are going to ask you its nerve supply, what will you write? Excellent, doctor. Excellent. It is going to be supplied by the lingual nerve carrying the taste sensation. Excellent. Identify the pointed structure. That's going to be the slide of pancreas. Yes, you can identify the endocrine part. This pale one is the exocrine part of the, endocrine, sorry, right? The exocrine part forms the acini, the serous part, secretion. The islets are the endocrine part. And recent instead they've asked you the histological image of suprarenal gland, and I told you epiphyseal cartilage. I asked you to prepare for tooth also. Okay, a similar images you can confuse with the like over the glomerulus of the kidney, right? Paler areas, parotid also, right? Serous acini will be there more in the parotid. Yes. Here again, so please do read about the parotid swelling. What are the structures within the parotid gland from superficial to deep, right? The secretomotor pathway of the parotid gland, the Frey's syndrome. So pain in the parotid gland is due to the unyielding nature of the deep cervical fascia. Excellent, Dr. Shweta. Excellent. This one, that was also in 2022, I think. It was an easy question. I'm sorry, what was the chart? Ma'am, can you show the papilla slide once more, once upon your free, right? One second. The circumvallate papilla, it's easy. You can see a valley, a groove on our entire surrounding the circumvallate papilla. These are the taste buds that you see here. And thanks for reminding. These are the von Ebner's glands that open into this sulcus. Thank you, doctor. Yes. So, the sensation over the face is it's by the trigeminal nerve. The muscles of the face is by facial nerve. And here, this area over the skin of the angle of mandible, patient losing sensation while shaving the beard, all that is because of that area innervated by great auricular nerve, ventral rami of C2, C3 coming from the cervical plexus related to the Frey syndrome, isn't it? What is the nerve supply to the tip of your nose? Put your finger on the tip of your nose. What is the nerve supply? Ophthalmic division. Upper eyelid, ophthalmic division. Lower eyelid, maxillary division. Upper lip, maxillary division. Lower lip, mandibular division. Okay, so the demarcating areas, make sure you know. This one, it was in 2021, I think, right? Yeah. So that is a coronal section. You can identify A, B, C, D. Yes, easy, right? They are talking about the tuberculosis of the lumbar vertebra, the psoas abscess. Yes. So here, A is the psoas muscle on either side of the lumbar vertebra. What is B? B on the anterior surface of the iliac bone, iliacus. C, any idea what is C? Coming from the hip bone towards the midline, your levator ani, and D in the gluteal region, right? This one, they keep asking about the blood supply of heart again and again, right? What is this? What is marked there is the septomarginal trabeculae that is traversed by the right bundle branch, which is supplied only by left coronary artery. Is that fine? There was recently a question on the interventricular septum, isn't it? Remember the right SA node, the AV node in the triangle of Koch are exclusively supplied by the right coronary artery. Similarly, the left bundle branch is supplied by right and left coronary artery, but the right bundle branch is exclusively by the left coronary and not right coronary. This one, cross section is which level? I've mentioned that, sorry. Yeah. Okay, so what are the features you would like to appreciate here? If you have time, just go through the INICET recall I've done recently in that ADRPLEXUS YouTube channel. You can see that I've discussed everything. This is the liver you can appreciate. Yeah, you can appreciate the IVC here. Can you appreciate the esophagus? Membranous part of the interventricular septum. Yes, what does it transmit will be the left bundle branch. The left bundle branch, that will be by the left coronary artery. Okay, doctor? Yeah. Coming here again, esophagus, the stomach. So this T10 level, what you appreciate will be the entry of the esophagus into the stomach, the cardio-esophageal junction. Okay. Remember the lungs, they end at 6, 8 and 10, right? Yeah. Okay. So here, please remember, I've just, in the recent INICET recall, I've just explained how to identify the section at T9, T10, T12 and L1. Make sure, if you're interested, go through that. Okay. This one, that was asked recently, isn't it? So what is the structure pointed out? Cross sections of thorax is also important. Yes, excellent. That is the pulmonary trunk. Okay, this is the pulmonary trunk. Yeah, you can appreciate. So here I'll take, yeah. So this is a section here. You can make out the descending aorta, the ascending aorta. This is the superior vena cava, close to the ascending aorta. Can you appreciate? This is the pulmonary trunk dividing into the right and left pulmonary artery. Just behind the pulmonary arteries, okay, you get to see something. It's going to be the bronchus. Please remember, just posterior to the pulmonary artery, you'll be seeing the bronchus. Okay, here the esophagus is very much narrow, right? This is the esophagus, close to it should be the azygos vein. Okay, look for the descending aorta, esophagus and azygos vein, the three features close to the vertebra, right? Now, anteriorly look for the ascending aorta close to its superior vena cava. And just to the left of the ascending aorta, you'll see the pulmonary trunk. Behind the pulmonary trunk, the right and left pulmonary arteries, the bronchus. Okay? And even posterior, yeah, veins, you can get to see the pulmonary veins. Again, cross sections of thorax also we have discussed earlier, right? You can just go through it. T4, T3 to T4 level, mainly you see the arch, right? Yeah, sorry, here. Just one point I'll tell. If you see the you can see the arch of the aorta, it's going to be like T4, T5 level. Okay. And here, if you see the branches of arch of aorta, brachiocephalic trunk, the left carotid, common carotid and the left subclavian, it is just above the T3. Okay. And this one is going to be below T4. T4 is the arch, branches will be T3 and below, right, ascending aorta, descending aorta is going to be below T4. And all the chambers of the heart will be lower thoracic level. This I just want to explain about the constrictions of the esophagus, okay, and the anterior relations. Maybe this part can help you. How I remember, I can teach you, okay. So just make this column. I'll put A, B, C, D. A, B, C, D. The first constriction is at the cricopharynx level. Second constriction was crossed by the arch of aorta. And third constriction is at the left bronchus. And the last one, the diaphragmatic opening. Vertebral level of cricopharynx, where the pharynx becomes the esophagus, the larynx becomes the trachea, C6. And arch of aorta, T4. Crossed by left bronchus, T6. Remember C6 and T6, they don't come nearby. Okay. Diaphragmatic opening, T10. And distance from the incisor teeth, 3 times cable. 6, 9, 11 and 15 inches, isn't it? And if you do centimeters, 15 centimeter, 25 or 23 centimeter, 28 centimeter, 40 centimeter. So whatever the case scenario is put and the question is related to esophageal constrictions, this cable is going to be useful for you, right? And abdomen relations of this kidney, duodenum, pancreas, is important? Can you tell me the answer alone for this? Yes, the left kidney. Here it is related to. Guys, are you there? Yes. Okay, stomach. So here will be your left suprarenal. This is spleen. This is the stomach. Here you have the tail of the pancreas, the splenic flexure of the colon, the coils of jejunum. Right? Excellent. It is the stomach. This one, easy. Histological image of, yeah, kidney. Just remember PCT and DCT. It's going to be simple cuboidal epithelium. The only difference is that PCT has the microvilli. Remember microvilli. Okay. Here, identify the type of bronchi. I'll just give you one clue. Okay. You have two bronchus, the terminal bronchiole. Difference. I have a question coming up. Okay, if you stay with me, Dr. Ajay, in another 5 minutes, we can discuss the right and left suprarenal gland. Okay, the terminal and the respiratory bronchiole. Okay, they are lined by simple cuboidal epithelium. There's going to be no glands. There's going to be no goblet cells. Okay, yeah. But one main difference, okay, in the terminal bronchiole, you can get to see cilia. Respiratory bronchiole, there is no cilia. And because of the opening, what is pointed out here is the respiratory bronchiole. In the respiratory bronchiole, the wall is interrupted by the opening of the alveoli. Both the bronchioles, you can see nice smooth muscle in the wall. Smooth muscle wall. And what is the special type of cell situated in the bronchiole? Can you tell me? The Clara cells. Okay, respiratory epithelium is again important. Please read about that. Here, yeah, Dr. Someone is asking about me about the suprarenal, right? So this is the right suprarenal. This picture should be very clear to explain it. This is the left suprarenal. It is pyramidal in shape. This is crescentic in shape, right? So the right side will be mainly, you can see the IVC is cut, right? The IVC and the liver. The IVC and the liver will be related to the right suprarenal. Here on the left, yeah, both will be related to the diaphragm. Here mainly related to the left side spleen and the stomach. Okay, and one more important thing. The hilum of the suprarenal gland is the part where the vein exits. So on the right, it is on the anterior surface close to the upper end. Whereas for the left suprarenal, you can see the hilum is related close to the lower end. Lower end. It's a small gland, right? A lot to talk about. Remember, in head and neck, every word about palatine tonsil is important. Similarly, suprarenal also is becoming important now. Adrenal cortex develops from the intermediate mesoderm. What about the adrenal medulla? Adrenal medulla develops from the neural crystals, isn't it? Blood supply of adrenal gland. The superior suprarenal artery comes from, come on, inferior phrenic artery, right? The middle suprarenal artery comes from direct branch from abdominal aorta, and the inferior suprarenal artery comes from the renal artery. What about the venous drainage? The right suprarenal vein will drain directly into the inferior vena cava. The left suprarenal vein will drain into, yes, waiting for your answers. Left suprarenal vein is going to drain into the left renal vein. Also do remember that nutcracker syndrome, Wilkie syndrome, that's the left renal vein is getting caught, right? Yeah. Okay. So suprarenal histology is also important. You must have seen through it, right? This one, the pointed structure projects to which thalamic nuclei? What structure is pointed out here? That's the, yeah, what is pointed out there is the mammillary body projecting to the anterior thalamic nuclei. So we have the fornix from the hippocampus projecting as white matter bundle into mammillary body, from that to the anterior thalamic nuclei, from that to the cingulate gyrus, entorhinal cortex, and back to hippocampus, forming the Pappi circuit for attention and reason memory. Okay, they keep asking this again and again. I'll just put one extra question. Let me see how you're prepared. What is the relation of fornix to the lateral ventricle? Anterior wall, posterior wall, roof, floor, medial wall, lateral wall. Can you tell me? The fornix will form the, it is not in the roof. The roof is formed by the corpus callosum. Okay. The medial wall is formed by septum pellucidum. The medial wall, it separates the lateral ventricle of the right and the left. There is no connection between the lateral ventricles of both these sides. Okay, medial wall is formed by the septum pellucidum. The roof is formed by the corpus callosum. And the floor for the anterior horn will be formed by the caudate nucleus. For the middle part, you'll have the body of the caudate nucleus, the thalamus, even the fornix there. Right? Fornix, not the lateral wall. Okay, lateral wall will be the fibers coming from the corpus callosum, the tapetum, all that. Okay, inferior hall. Recently, they asked in NEET, right? What are the structures forming the roof of the inferior horn of the lateral ventricle? The tail of the caudate nucleus. Any idea what is, if this is the tail of the caudate nucleus in the roof of the lateral ventricle, inferior horn, what is this structure that lies in contact with the tail of the caudate nucleus? Any idea? It is the amygdala or the stria terminalis that comes from the amygdala. Okay, so please read a little bit about the lateral ventricle, third ventricle, and fourth ventricle. This is easy. The market cells. This is again another high yield topic, cerebellum. Like I told you, palatine tonsil, suprarenal gland, cerebellum is, every line of cerebellum is going to be important. What are the Markov cells? These are the Purkinje cells, right? And they inhibit the deep cerebellar nucleus, the dentate, emboliform, globose, and vestigial. You should be able to identify the dentate nucleus in a cross section of cerebellum. Is that fine? This is a tricky question. I just put it for you. Which of the following joints are contributed by the bone given? So what you see here is the rib. Anteriorly, which is the anterior end of the rib, where it's going to give attachment to the costal cartilage. This is posterior end. This attachment with the costal cartilage, this is going to be a synchondrosis, primary cartilaginous joint. Right? And here it's going to articulate with the vertebra, right? The transverse process and the body of the vertebra forming a plain synovial joint. Excellent, doctor. Plain synovial and synchondrosis. NEET-PG 2022 they've asked, right? So what is the reason for the pudgy orange appearance? Blockage of the subcutaneous lymphatics. You see the hair follicle, between the hair follicle, the area sort of puffed up. It's because of the occlusion of the subdermal lymph. Sorry, Dr. Harish. Yes, I'll give you the previous slide. Right? So, pudgy orange appearance is due to malignant infiltration into the subdermal lymphatics. What is the reason for retraction of nipple? Retraction of nipple. Okay, Dr. Harish? Retraction of nipple. What lies underneath the nipple? What lies beneath the nipple? You see the opening of the lactiferous duct. If you remember this concept, you'll never forget it, Dr. Maunapriya, right? So underneath the nipple, you have the lactiferous duct. So malignant infiltration into the lactiferous duct is responsible for retraction of the nipple. The dimpling of the skin, the fixity that you see is all because of, dimpling is because of, these are the ligaments of Cooper that extends all the way from the skin to the underlying mammary bed structures. Yes, Dr. Moga. Okay, so infiltration into the Cooper's ligament will cause dimpling or puckering, isn't it? Okay, ligament of Cooper. And this one, fixity to Yes, doctor. Yeah, soon after this it will be shared, okay? Yeah. If I don't, just send a reminder. So this one here, I just need your feedback. Okay, your feedback is the one ultimately that motivates. This fixity to the underlying breast tissues because of infiltration of malignant cells into this white space that you see here. Yeah, separating the breast into the mammary bed structures, into the retromammary space. It is mobile. Do you think the breast is mobile just because it's sitting over the serratus anterior? No. The presence of the retromammary space, okay, that loose areolar tissue beneath the breast and the pectoral fascia that covers the pectoralis major. This is the answer. So we'll just see it again. This purely orange appearance is due to infiltration into subdermal subcutaneous lymphatics. Retraction of nipple due to infiltration into the lactiferous duct, and puckering or dimpling of the skin is due to involvement infiltration into the ligaments of Cooper. Fixity of the breast tissue is due to infiltration into the retromammary space. This one, I think this is the last slide. A patient of splenomegaly preventing downward enlargement of the spleen. Which ligament? Easy. Yeah, excellent, 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 excellent. Okay, so this is the phrenicocholic ligament. You know where it extends from? It extends from the left colic or the splenic flexure to the diaphragm. On the way, it suspends the lower end of the spleen. Okay, so that prevents the downward extension, and you can see the spleen going towards the spino-umbilical line all the way towards the right iliac fossa. Okay, guys. So thank you for continuing to stay with me till the end. Thank you, doctor. Yeah, what do I want and need in deal? What is the deal? So if you have found on two things, if you have found this session useful, just put a thumbs up before you leave. And in your Google form, your feedback form, just give me your motivation. Okay, if possible, we can try to get another session also with other important points that we have left back over the previous year question. Thanks a lot. Have a great day.